would like to welcome you all to Cady Wellness Institute tonight for a great start, hopefully, to your year 2013. The presentation that you will see tonight is a modification of one that I gave in Las Vegas, Nevada, to the American Age Management Medical Association. My notion tonight is that saying that you've heard, what happens in Vegas stays in Vegas, is not true, because what happened in Vegas I brought back to River City to share with my friends and some of my patients and also the WNIN audience. So with that, let us begin. Where I trained at Mayo Clinic, there were two sons of William Worrell Mayo, known affectionately as Dr. Charlie and Dr. Will, and they were always worth quoting. Dr. Charlie said there are two objects of medical education: to heal the sick and to advance the science. And Dr. Will said the glory of medicine is that it is always moving forward and there is always more to learn. And I think as physicians, we need to think about that, believe it, and practice it, and keep learning. And the more I practice, and the more fun things I see with patients, and the more wonderful ladies I meet, like this one coming in tonight, the better it gets. So here are the purposes of this talk. We're going to talk about real-world clinical applications of age management medical concepts. We are going to talk about, don't assume you're just, quote, depressed, unquote, or somebody is just depressed. It could be a biological problem. We'll talk about thyroid, cortisol, and several other hormones, and then I'm always interested in things that make it inexpensive and affordable for patients. So we're going to talk about cost-effective ways to screen for hormonal and neurotransmitter abnormalities. Now, this was just featured in the New York Times this week, and this is the differences in life expectancy in the years 2006 to 2008 for us versus the rest of the world. So everything on this chart is us, men and women, and down here you can see that from birth to the age of 50, we are in about the 17th from the top in terms of industrialized country, in terms of health and life expectancy and freedom from disease. That's the bad news. The good news is, if you manage to live to 80, and particularly up to 100, I mean, you're golden. If you're 100, you're going to be in the second highest. So if you're here, bad news. If you survive to 80, good news. Is that the way we want to live in this country? Here's another statistic. This is the current and future obesity rates. And I would like to call your attention to the tri-state area of Illinois, Indiana, and Kentucky, the WNIN viewing audience, and my people here in River City. So when we look at Indiana, just looking at Indiana, in 2011, 25%, 1 out of 4 people in Indiana are obese. And if the rate continues, then in 2030, if we actually improve the average body mass index by 5%, about half of the people in Indiana will be obese. And if we don't, 56% of Indiana people will be obese. Now, that's not just a little overweight, that's significantly overweight. This is the health of the country that we're talking about. So some years ago, as I was conceptualizing Cady Wellness Institute, I decided that the best way to practice medicine and evaluate people was to integrate the mind and body for peak performance. In fact, that's what it says on the business card. So I'm going to deconstruct the logo that you might have seen. This is an integral sign in calculus. It means you integrate. So you integrate the mind and body for peak performance, arranged around this triadic model of the body, which is the foundation, the mind, and then the actions that we perform. And these are the only 3 things that can be done to influence human behavior and performance. You can intervene on the body, you can intervene psychotherapeutically, you can shrink them to the mind, and you can do behavioral therapy, like you might want to consider exercising, you might want to consider decreasing calorie content, and so forth. The problem is that in psychiatry, which is the field that I started out in, people are stuck on the mind. It's like, oh, well, you must be neurotic, or you must have poor self-discipline. Or some of my patients say, well, I can't figure out what's the matter with me. Something must be the matter with me. You know, I'm wondering if it's my self-discipline, and I just can't seem to get going, and I'm overwhelmed. And that's where we begin overly focusing on the mind instead of the body. So I'll show it to you one more time, the body. This is the neurovitality process that we use, and again, it is foundationally supported by emphasis on the body, the mind, and actions. Not body, mind, and spirit, as one of the local healthcare groups has it, but body, mind, and actions. Because once your body is set up correctly, once you are psychologically set up correctly, then you have to take action. And we will talk about actions tonight. And only 3 ways that you can actually intervene in human performance, but the body is foundational. So we're going to talk a lot about the body and biology and hormones tonight. Okay, this is what one of my patients had to say about her current medical care. They just monitor my degeneration. Or, as another wit remarked, so, yeah, we don't want to let it go until that point. When we look at what's been published in the peer-reviewed literature, this was the American Journal of Health Promotion, and basically it's a 2/3, about 2/3 in the middle, 1/5 and 1/5. So here it goes. It's kind of like the goalpost. There are 2 extremes of the health continuum. Dead, that's really bad. And then over on the right is optimal health. And so right in the middle, you've got 66% of the population that is incompletely healthy. They're not really sick, but they're not really well. Then you have 1 out of 5 who are completely unhealthy. I mean, cancer, arthritis, high blood pressure, high cholesterol, they've stroked out, they've had a heart attack, completely unhealthy. And then about 1 out of 5 were completely healthy. Now, where would you like to be in that? I vote for completely healthy, but there are specific things that you have to do to be there. So here's how to get the most out of this presentation. The former teacher in me wants to clue you into this. Listen for the intersection of the clinical histories and some of the data points that are going to be presented on the slide. I will use color to tie things together or set them apart from each other. So just relax. It's not going to be one of those expert slides that these 2 pharmaceutical reps have seen, you know, with the itsy-bitsy white print and not much graphics. And then this is how you get the slides. So this is for anybody that watches this on WNIN, sees it on the website, or anybody here. You can go home a little bit later tonight, go to slideshare.net/LKDMD, and you can look at every slide. And there's a little thing here, full screen display. It's a little square at the bottom. Click on that, it'll blow it up so it fills your computer screen. So you can go over every slide. All right, now here's my philosophy about practicing medicine and psychiatry. This is my transcranial magnetic stimulation chair. It zaps depression away with magnetic pulses. No meds, no side effects, or minimal side effects. It's remarkable. It's not a seizure, it's not shock treatment. My philosophy is whatever it takes. So this is what it takes sometimes to get people well from depression. But certainly we need to start with the simple things, the foundational elements, the body, before we go to something like this. So here are my topics tonight. I'm going to talk about thyroid, cortisol, DHEA, some female hormones, some female and male hormones. I'm going to talk about, do you spit in a tube or get poked with a needle, saliva or blood, and then finally, weight loss. I'm going to talk about that last because the hormonal stuff is kind of foundational. So this is from the LabCorp manual in terms of how to work up the thyroid. And this is what it says. The cascade begins with a 3rd generation TSH, thyroid stimulating hormone test. If the TSH is normal, there is no apparent thyroid disorder and no further testing is warranted. There is one problem with this, and that is it is wrong. And I will show it to you. In fact, I see some people in here who have had their life altered by people overly focusing on the TSH. Here's something else. The American Association of Clinical Endocrinologists also agrees with that. Here it is. The sensitive thyroid stimulating hormone assay has become the single best screening test for hyperthyroidism and hypothyroidism. There it is. And it is the serum TSH, the most sensitive test for detecting mild thyroid hormone excess or deficiency. Again, wrong. So LabCorp's wrong. American Association for Clinical Endocrinology is wrong. What's this shrink in Newburgh? Where does he get off saying that these people are wrong? And I'm going to show you. Because when you go, oh, here's somebody else. This is TSH is the most sensitive indicator of hypothyroidism. This was a website accessed September of 2011. It was none other than the University of Maryland Medical Center. This is not a fly-by-night outfit. Now, they're getting with the program, though, because they modified their website. And now they say blood tests for measuring levels of TSH and free thyroxine are the only definitive way to diagnose hypothyroidism. October 2012. That's progress, but it is also wrong. So, here's what happens with your thyroid. And you don't have to strain because I'm going to draw boxes around each one of these things. The pituitary, this pea-sized gland in your brain, secretes thyroid-stimulating hormone. That's what they're talking about checking. Thyroid-stimulating hormone goes to the thyroid gland and tells the thyroid gland, make thyroid hormone. That is T4. Thyroid hormone goes all around the body, and it is predominantly metabolized to what's called free T3 in the liver. Free T3 is the foot soldier of the thyroid gland. You don't have enough T3, you're hypothyroid. Doesn't matter what your TSH level is. Unfortunately, this is not understood. So you have to have selenium for this to happen. Make a note of that. Selenium is required. Okay, now, meanwhile, over on the other side, if you're under stress, your body secretes cortisol. Cortisol shunts the production of free T3 over to reverse T3, the evil twin of T3, which will bind into receptors and block the action of T3. So now with stress, you have the antidote for T3. So you can see it's not just this, it's this, the University of Maryland got that right, plus this, plus this. Now you have a reasonably complete thyroid panel. So if your doctor has said your thyroid is fine, you need to find out what level was checked and what the number was. So this feedback, but it actually gets worse. Reverse T3 floats around in the body, goes back up to the pituitary and says, I'm T3. I'm T3. You don't have to keep secreting TSH, even though it's not the kind of T3 that will do you any good. So TSH goes down. So now your TSH looks normal, and you're still feeling like you know what. That's the problem with just checking TSH. Now, remember I said that that enzyme was selenium dependent, this one right here, that makes free T3, the foot soldier, what actually does the deed out there. Well, this was the United Nations Earth Summit. It looked at percent mineral depletion of soils in the last 100 years. North America is again leading the world, this time 85% soil depletion of minerals. I was just reading the other day about George Washington Carver that said a man should aspire to leave the soil better than he found it. Unfortunately, with a lot of agricultural processes, that's not happening. And so when you deplete the soil of minerals and you also deplete selenium, you get selenium deficiency. And what this FACEB journal said is basically that modest selenium deficiency can increase the risk of diseases of aging. And one of the ways it does that is it interferes with the production of adequate free T3. Now I'm going to show you what hypothyroidism looks like when it walks into my office. Can I lower these lights for just a second? All right, we're going to, this is like really show and tell. And I'll just stand over here. I want you to direct your attention to the missing outside eyebrows on this woman. This is one. This is another one. No eyebrows. This is a 20-year-old college student who came to CWI to see Dr. Gabhart, actually, no eyebrows. And this is what she said. She said that she had gained weight, had fatigue and brain fog, that she had seen numerous MDs asking for help, and she was told nothing is wrong with your thyroid and your labs are fine. This is a young lady that heard my talk in Santa Fe, New Mexico. You will think that there's nothing wrong with her thyroid, at least from her eyebrows, because they look really good. But she came up to me later on and said, "Did you see me crying during your talk?" I said, "No." She said, "That's me." She said, "I had to have my eyebrows tattooed on because they wouldn't grow. And I had been to doctor after doctor after doctor, and they all said, your thyroid is fine, so I had them tattooed on." That's what happens when you don't pay attention. So I'll flip this back up. Whoop, not that one. Here we go. So let's talk about how you can be misdiagnosed with depression. If you look at the major symptoms for depression, obviously most people with depression have depressed mood. They have impaired concentration, but other than that, it's all about energy and fatigue. Reduced energy, loss of energy, tiredness, hypersomnia. These are some of the big features of depression. And so you can have somebody that really isn't depressed, but they come in and they say, you know, I'm tired, I'm feeling depressed, I can't concentrate, got no energy, and the doctor says, oh, you're depressed, have some Prozac or have some Zoloft. Instead of, maybe your thyroid is low, let me run a complete thyroid panel on you, and by the way, I'm going to check your estrogen, progesterone, and testosterone at the same time while I'm at it. This leads into a discussion of, are you ready for this? Are you sure you're ready for this? Statistics. I once gave a talk, and I prefaced a statistical discussion with, does anybody here love statistics? One woman put her hand up, said, I do. It was my wife. But this is a bell curve or a Gaussian distribution, and right here in the middle, 2 standard deviations to either side. This is what's considered normal for labs. This means you're not way up here or way down here. So if you're here, you're normal. So nothing is flat. Maybe that's not good enough. Maybe we need to be within 1 standard deviation. Maybe that's better. Is that good enough? How many say it's good enough? How many say it's not good enough? Oh, I am talking to my people. Yeah, this is probably good enough. This is optimal. So, do you want normal or optimal? I love what one of my mentors, Neil Rousier, says about normal. He says, when your lab values are as crappy as everybody else's, that's normal. May not be optimal. So, what I'm going to propose is that we have come a long way in our thinking. And this used to be the picture, and, you know, doctors pose, and, you know, more doctors smoke camel. That was then. This is now. Simply because everybody has done it that way up until now does not mean that that is the way to do it. So, let's talk about conventional practice for automobiles and age management for automobiles, and I think you can see where I'm going. I'm actually going to overcome the objections from the traditional crowd up front. So, conventional practice for automobiles is no fuel additives should be used. They are unnatural. Gas is all that is required. Age management for automobiles says there are fuel additives that we can use that actually help our cars burn cleaner and preserve engines. We should use them. Again, conventional medical practice for cars, the quality of the gas is irrelevant. Anything that will burn in the motor is perfectly adequate. Age management says we should use optimal quality gas. Conventional medical practice says preventative maintenance for cars, this is silly. Wait until something breaks and have the car towed in so the mechanic can really tell what is wrong. That's conventional. Age management, we should take our car in for preventative maintenance before anything breaks. That way, maybe it will last a long time. Okay? Which way do you want to treat your car? And then, do you really want to wait until something breaks and never change the oil? Because changing the oil is unnatural. It is natural for oil to get dirty. It is natural for particulates and microscopic metal thingamajiggies to mount up in your oil. It is natural for it to turn dark and to stop being as lubricating as it was originally. Do you really want to run your car for 50,000 miles with the same oil? Well, if you say no, then conventional practice would say you're being unnatural. You're intervening in something that is the natural order of things. Everybody knows those old people, their hormones, we just let them go, Just let them go down. Don't intervene, Who cares about sex? Who cares about weight? Who cares about preservation of brain function? And I just don't think that's a good way to practice. So, do you want normal or optimal? Do you want a normal wife or husband or an optimal one? Do you want a normal marriage or an optimal one? Do you want a normal sex life or an optimal one? I thought about footnoting that, but I decided not to. Would you like normal labs, ladies and gentlemen, or optimal ones? How many say normal? How many say optimal? Yeah, optimal. So we're going to talk about that. I'm going to start, don't freak out, I'm going to break this down. I'm going to make it painless. But I'm just showing you my primary document. So this is fatigue in patients with coronary artery disease, association with thyroid hormones. So Psychosomatic Medicine 2012, what they found was that serum concentrations, or what they looked at was serum concentrations, blood, of free T3 and free T4, and morning cortisol. That's all I'm going to tell you about that. They adjusted for different things. When they adjusted for different things, this is what they found. Here's the payoff. The lower your free T3, the more physical fatigue you had. The lower your free T4, the more exertional fatigue that you had. And the lower morning cortisol and changes you had, the more mental fatigue. I'm going to show you some cortisol in a minute. But do you all see that low free T3 and low free T4 is bad for you? Might have something to do with how your brain is working. Move your head up and down. Okay. Good. Now, but TSH is the only thing that gets checked. Is that acceptable? No. Okay, here's another one. This is using adjunctive treatments when first-line antidepressants fail. Journal of Clinical Psychiatry, January 2012. Treatment-resistant depression is a common challenge. I see it all the time. There are two augmenting strategies which are frequently used, lithium and thyroid, as well as anti-anxiety medications and atypical antipsychotics. This is a breakdown of a highfalutin study in my area of expertise, psychiatry, called the STAR-D trial. And basically they started everybody off with generic citalopram. It's cheap, it's effective, it works for a lot of people. And if it didn't work, they kept going down and down and down until they got to level 3. At level 3, they looked at lithium versus thyroid hormone. Lithium and thyroid hormone, T3, thyroid hormone. What they found was, in terms of scoring it, that's a Hamilton Depression Rating Scale, 16% got better on lithium, 25% got better on T3. That's almost twice as good. That's thyroid, ladies and gentlemen, not a, quote, psychiatric medication. It used to be thought that free T3, Cytomel is the brand name, or liothyronine, had antidepressant effects. Well, it probably does, but it's not because it's like a super Prozac type deal. It's because it actually corrects underlying subclinical hypothyroidism. And if you are subclinically hypothyroid, you will feel depressed. This is interesting. Prevalence of depression in patients affected by subclinical hypothyroidism. There's kind of a twist here. 63 patients with what was referred to as subclinical hypothyroidism had their thyroid labs done. Their serum TSH, their free T4, their free T3, and this is some thyroid antibodies. The prevalence of depressive symptoms in this patient population that was subclinically hypothyroid was 63.5%. Now let me put this in locally friendly terms. These are the Casino Aztar betting odds on your chance of being depressed if you are subclinically hypothyroid, and your chances are 63.5. Taking another step, if you went to the boat, which I counsel patients not to do, and you could be correct 63.5% of the time, you would beat the house. Okay? This is a lot. Now, I want you to look at what the conclusion was. This study suggests the importance of a psychiatric evaluation in patients affected by subclinical hypothyroidism. What? How about we give them some thyroid hormone, and then maybe they wouldn't be depressed. So when people come in, but this is common, this is the common medical paradigm. Now, I love my medication options that I have to treat depression. Wouldn't want to give any one of them up. I love my potions. But I hate using them if there is a biological problem that is undiagnosed and untreated. You cannot fix low thyroid with an antidepressant. You can symptomatically band-aid it, but you can't fix it. Here's another one. Now, that's mood. Now we're going to talk about cognitive dysfunction. And I have some older friends in the audience tonight. So this is subclinical hypothyroidism and cognitive dysfunction in the elderly. This was to evaluate the relationship of subclinical hypothyroidism and cognition in the elderly. 337 patients. Many mental status scores were significantly lower in the subclinical hypothyroid patients compared to euthyroid. Now, the fancy term is P less than 0.03. This is 3/100ths of a chance that this was due to random happenstance. In other words, this is pretty doggone good. And the conclusion was patients with subclinical hypothyroidism had a probability about 2 times greater of developing cognitive impairment. Do you really want your mother or grandma to be low thyroid and just let her get demented or demented in appearance and function? It's not that she has an Aricept deficiency, it may be a thyroid deficiency. All right, I would like to tell you the story of the glamorous grandmother, somebody that I have presented nationally. This is an 80-year-old lady returned to my practice, no real complaints, history of depression. She was on generic Effexor. Her daughter was handling her finances. In May, she was doing terrible. Her TSH was 3.84, which is normal. Her free T3 was 2.8, which is normal. She was on a perfectly normal dose of thyroid. You're hearing a theme here? Normal, normal, normal. Her fasting blood sugar was 120, and her glycosylated hemoglobin, this is a marker for too much sugar, was up. Fasting insulin was up. Progesterone was at the very bottom. Her total testosterone was 11. That's normal. Optimal is about 50. Her DHEA sulfate, which is a hormone that has to do with energy, was at 25 micrograms per deciliter, one of the lowest that I've seen. Age-adjusted range is 10 to 90. Optimal is 350 to 500. Neil Rouzier, who I quoted a while back, likes it about 300 for women. That is, let's see, that would be 4 times too low? That's 12 times too low. So, use some DHEA, use some progesterone, use some testosterone, and send her to a better MD for workup of the diabetic issues. June, she came back less fatigued, labs were rechecked. July, feeling wonderful. This is what happened. Her TSH, remember this is the only one that you're supposed to check, 3.84. In July, 3 months later, it was really low, 0.01. This is the kind of thing that will freak out doctors. They will say, you're burning the calcium right off of this woman's bones. You're going to make her hyperthyroid. You're using too much thyroid. But I actually wasn't, because the free T4 was normal and the free T3 was normal. Her progesterone was better, her testosterone was better, and I missed rechecking the DHEA. She was lots better. All right, so what are the differential effects on estrogen and progesterone in women? I'm going to break this down easy. This is 24 postmenopausal women with an intact uterus. That means they hadn't had a hysterectomy. They had neuropsych testing and no hormone therapy used, and they were recruited by newspaper ads. They were randomized to conjugated equine estrogen, CEE, and placebo. That, ladies and gentlemen, is horse urine estrogen. Premarin, pregnant mare urine. Premarin. Conjugated horse pee estrogen. It's interesting that I have never seen conjugated horse pee testosterone used in men. Stop and think about it. But anyway, this was conjugated, this is Premarin plus, this is medroxyprogesterone. That's the bad one. That's Provera. That's the one that can give you breast cancer. And then this was the Premarin and micronized progesterone, which is good. Everybody's mood improved. Oh, gee, this is difficult to read. The conjugated equine estrogen and the medroxyprogesterone, in other words, Premarin and Provera, did significantly better on a test of working memory. So does that mean you should give women Premarin and Provera? Well, not so fast. This is Provera in women and rats. It's used in hormone therapy as Depo-Provera. It's implicated in detrimental cognitive effects in women. When you cut out the ovaries of a rat and you give them medroxyprogesterone, it impairs their cognition. And findings suggest that using this treatment can lead to long-lasting cognitive impairment in the rodent, even if you stop using the medroxyprogesterone. Question, as Dirty Harry would say, do you feel lucky? Do you really want to be on something? I mean, it doesn't say that it has this effect in humans, but the rats are pretty good experimental models. I really don't want my women patients to be running the risk of this. So let's talk about thyroid and the hormones, because I'm going to wrap up thyroid and continue. Thyroid is not just about the eyebrows. Low or subclinical hypothyroid is associated with depression, mental fatigue. It's actually associated with higher risk of suicide, poor cognition, and twice as likely to have cognitive impairments. Now I'm going to shift from women to men for a second. This is a 53-year-old male executive that came to see me. He was a partner in 4 businesses. The last year or so, I'm more tired, don't have the energy. I'm having more trouble getting out of bed in the morning. And you can see why, because when you look at his cortisol levels, should be in the green. Cortisol should start up here first thing in the morning. This spike up is associated with getting up out of bed and then decline. He was barely functioning, and by nighttime he'd shot his load of cortisol, and he was now subnormal, not suboptimal, subnormal. So when I did his salivary testing, his DHEA was pathologically low. His testosterone was close to the bottom. Was it normal? Yes. Was it optimal? No. And then I also did some labs, and his TSH was also not optimal. It was normal, 303. Here's 230 to 420. I'll tell you how I sometimes tell patients this. I say, okay, I will give you a free house. I mean, I won't really, but this is a thought experiment. A free house. Your price range is $230,000 to $420,000. I will pay for it. You can move in. Somebody said, does it come with a maid? Yes, it comes with a maid. Okay. Would you really stop at 303? Or would you go for the gusto of 420? Which is normal, which is optimal? So these were normal, they were not optimal. So his DHEA was low. Most doctors don't check it. It's produced in the adrenal cortex. That's these little walnut-sized glands on both sides, up here, up top your kidneys. We and the apes are unique in that we secrete a lot of it. Why? To deal with stress. And it also supports the sex hormones as well. It boosts the immune system. It improves insulin receptor sensitivity. It gives us more energy. And it boosts growth hormone, to address a question that came up earlier. 20% in men, 30% in women, as a heck of a lot cheaper than growth hormone. So, and it has antidepressant effects. So I ran to PubMed, and this I will encourage you to check this site out for anything that you want to know. PubMed.gov, not Club Med, but PubMed. Just think, published medical .gov, G-O-V. This is like we're from the government and we are here to help. Okay? Now, if I've told you that, you can remember PubMed.gov. So, the study, this search on DHEA with fatigue in October found 110 citations. And if you look at DHEA with energy, 349 citations. And this is available on the shelves of particular places in Evansville, Indiana, and Henderson, and Owensboro. Cheap. But I suggest you don't go and just buy some. You need to know what your levels are. Here are some other interesting points about DHEA. We don't really know how it works. There's no nuclear receptor for it. We don't really understand everything. Some actions may be through the conversion into more potent sex steroids, and that includes, ladies and gentlemen, testosterone. If your DHEA is low, your testosterone will probably be low. It stimulates neural growth, actual brain cell growth. DHEA increases the length of axons. Those are like the cables of the neurons. And the DHEA sulfate, which is another form, stimulates the dendrite growth. Those are like the bushy things that sprout out of neurons and talk to other neurons. So it's really good for your brain. It promotes the survival of the adult human cortical brain tissue in a test preparation. It increases neurogenesis. That's making neurons, branching out. It increases neurogenesis. Don't you think you ought to have some of that stuff floating around, like maybe an optimal level? I certainly do. This was a study, the role of DHEA in terms of problem solving. It's low DHEA has been correlated with DHEA has been correlated with lower susceptibility to anxiety and mood disturbance. That's if you have enough of it. So they gave people a behavioral task, which is where they gave them anagram puzzles ranging from the possible to the flat-out impossible. And they also looked at their ACT scores, the number of college classes that they had dropped or failed, and their current grade point average. What they found was the higher the DHEA to cortisol ratio, the better people did. In other words, more DHEA equals better brain performance. This was another one. This was behavioral and physiological correlates of stress related to examination performance in college chemistry students. Now, this wasn't just any kind of chemistry class. This was the deal buster for pre-med students, organic chemistry, one of the hardest courses I ever took. 91 students taking this organic chemistry course in the USA were evaluated, and what the experimenters looked at, they looked at, did they fidget while they were taking tests? Those were displacement activities, moving around, fidgeting, drumming their fingers, and that screened for by video recording during test. And they found that the salivary hormone levels of cortisol and DHEA correctly predicted 90% of the students that would pass the class. 90%. Again, don't you think this is kind of important, this DHEA stuff? I'm not going to ask my patients, that some of whom might be in the room, to raise their hands for this, but for everybody else, how many of you have had a DHEA level checked? You have? You have? My congratulations to your physician. So 2 people. That's way too few. So what did I do for this stressed executive? I gave him a little bit of Armour Thyroid, which is a really good thyroid replacement. I started him on DHEA and moved it up. I gave him a high-potency multivitamin with high-dose B, C, and minerals. And 5 months. This is what happened in 5 months. I think all the stuff is working, energy level is good. If there is anything lingering, it's just stress. I actually feel pretty good. I asked him on a 0 to 10 energy scale where he felt. I said, what did you feel like when you were 24 to 25? Said, I felt like I was a 10. How did you feel before the labs and interventions? 4, then 5 to 6, then 8. I'll take 8. I mean, I think it might be unnatural to get him back to where he was at 24 to 25, but 30s, mid-30s, I can do that. Here are his labs. His free T3 went from 303 to 361. His DHEA tripled. And as this happened, this is the foot soldier for growth hormone, IGF-1. This is what will cost you $1,000 a month to get increased. His went up 50% on just these interventions alone. His testosterone went up. And his free testosterone went up because I was giving him a little testosterone. This is a complete balanced hormone approach. Now, do you want spit or blood? Here is the way I look at it. Saliva, you can get a lot of tests, and it's really inexpensive, and you can get a whole lot of information. You can get 4 different spits during the day, which gives you the cortisol rhythm, and you average them out. There's one lab that does this. You can get the average of 4 different measurements per day for those hormones. This is something you can't do with blood. The early morning cortisol is arguably more accurate than what you would get with blood. It's cheaper if cash pay, and it's perfectly acceptable as a screening tool. The problem is that when you start using hormones, it doesn't necessarily correlate exactly with the hormone, and the peer-reviewed literature is all about blood. So here's blood testing. More published literature looking at specific levels and more predictable dosing of hormones with very careful blood monitoring. So this is great for screening, and it's cheaper if it's cash pay. This is also acceptable for screening, and it's more accurate for follow-up. I think I'll skip that. So let's talk about estrogen as this monoamine oxidase inhibitor. Now, what the heck is that? Well, how many times have you ladies heard, well, it's just your hormones? Or you've heard somebody say to somebody else, well, it's just her hormones. Well, they were right. Estrogen, as well as testosterone, decrease this enzyme that exists in the brain. You can think of this enzyme as a little Pac-Man that eats up neurotransmitters. The more monoamine oxidase activity, the more neurotransmitters get eaten up. The more neurotransmitters get eaten up, the crappier you feel, and the worse your brain works. Is that clear enough? All right, so a number of studies have found estrogen and testosterone decrease this activity of monoamine oxidase. Here's another one looking at platelet monoamine oxidase levels are inversely correlated to estradiol. What that means is the more estrogen, the lower the monoamine oxidase activity. Everybody with me on that? Here's another one. Estrogen decreases monoamine oxidase A and B. And how many are there? 2, A and B. Now, wouldn't it be cool if we could do this like they did on Star Trek? I just love that. I was fascinated with Bones McCoy's sick bay and those levels that would go up and down. I particularly like this one. This was the cell rate. I thought that'd be pretty cool to know. But wouldn't it be cool if you could look at it like on a sliding deal? And actually you can. So this is the lab, the salivary lab for a low estrogen, DHEA, low cortisol, and low neurotransmitters in a 52-year-old woman having had TAH, that's total abdominal hysterectomy, total abdominal hysterectomy. She still had her ovaries, but her uterus was out, fatigue and depression. So here was her cortisol rhythm. It started really low in the morning and didn't rise. She was never in the green, so that means she was tired. Her adrenal phase, she was in adrenal burnout. Her estradiol level was less than 1. Now, this is a 52-year-old woman. 1 to 3.2 is postmenopausal. It's already less than 1. This is low. And remember what I told you about estrogen, estradiol, how it decreases monoamine oxidase activity? And if it decreases monoamine oxidase activity, that means the little Pac-Man aren't chomping up the neurotransmitters. Wouldn't it be cool to find out what her neurotransmitters were? How many of you would like to know what her neurotransmitters are? Okay, very good. So this is a urine test, which uses something called ELISA to get the neurotransmitters. And actually what we find here, the serotonin, GABA, dopamine, epinephrine, and glutamate are low. Low estrogen equals low neurotransmitters equals you don't feel good and your brain doesn't work right. Dopamine, norepinephrine. Okay, estrogen is good for your brain. Used to be, you know, when you hit menopause, no biggie because you were going to die pretty soon anyway, right? Now women are living 3 decades longer. It is protective against schizophrenia, estrogen. It's thought that that's one of the reasons that there are more guy schizophrenics. Isn't that interesting? Let's talk about traditional versus bioidentical. Let me define some terms. Synthetic means it ain't natural. It's made from outside the body. Bioidentical means it is exactly like what is inside the body, but it doesn't necessarily mean that it was made in a body. It can be synthesized in a test tube, but as long as it's the same as what's in the body, it's bioidentical. Premarin, horse pea estrogen, is bioidentical. It's not bioidentical to your estrogen, but it is, it's not synthesized. It's made naturally. Now, how many people in the room have heard or are afraid that hormones in women can give them cancer? Right. That is an aberrant, incorrectly abstracted notion from the Women's Health Initiative. It was a flawed study. It was designed as a Premarin and Provera study. So Premarin, that's horse pea estrogen. Provera, that's the stuff that will screw up rats' brains, right? I've been over that. Premarin is a non-bioidentical substance. It's bioidentical for a horse, but if you're not a horse, it's not bioidentical. Provera is a non-bioidentical substance, and yet this is the study that all hormone replacement therapy is indicted upon. 30-plus female horse hormones in Premarin. The conclusion was Premarin and Provera yielded these findings, therefore hormone replacement therapy is not appropriate for women. That's the take-home from this study. That is wrong. Here were the participants. 2/3 of the women were older than 60. That means, and most of them were first-time users, that means their systems had not seen estrogen for a decade. Therefore, they were already at risk for heart attacks and strokes because their bodies hadn't seen estrogen for a decade. Okay. Now, this is one of those good news, bad news situations. The bad news, you were more likely to die in the first 3 years if you were on it. That's bad. The good news is, if you were one of the lucky ones, and most were, the vast majority of women were, after 3 years and beyond the 8th year, the women that were actually on the hormones started doing better than the placebo group. Why? Because if the estrogen did, it's kind of like Nietzsche. That which does not kill me makes me strong. If the estrogen did not take you out, the horse pea estrogen and the fake progesterone, if those didn't take you out, then eventually you'd start to get cardiac benefits. The other thing is that these women were not pre-screened for heart disease. So when you actually look at the total number of participants, this is the hormone replacement group right here. This is placebo. 37% of the hormone replacement group had hypertension, 11% had high cholesterol, and 2% had already had a heart attack. Now, this is not a good study group to be making conclusions out of. The other thing is Premarin raises this inflammatory protein, C-reactive protein, significantly. That is an inflammation marker. That which causes inflammation causes people to break off clots and stroke out and have heart attacks. So this inflammation is either the root cause or strongly contributing to actually cancer and heart disease, inflammation. I don't particularly think that women should be on these things. Now, testosterone, there's a sexist bias against women. I already alluded to that earlier before we began the formal presentation and taping. And that is that women will be asked about how their sex life is, if they are asked, and they'll say, well, you know, not very good. And the physician, frequently male, will say, welcome to middle age. But if it's a man that goes in and they say, Doc, I'm having this problem. One of my patients calls it with old Herman. I'm having this problem with old Herman, and just not working. And I mean, then, oh, well, you poor guy, you know, let me write you some Viagra or Cialis. So the fall in circulating testosterone correlates with the adrenal preandrogens, that's like DHEA, as you get older. You actually have an acceleration in the years before menopause. So you can be a woman, you know, having periods, just normal as you please, in your 40s, and your testosterone level can be going down. You don't think you got a problem because you're still having periods. That's not a get out of jail free card. Just because you're having periods does not mean that your hormone levels are optimized. Your testosterone could be low. When your testosterone goes down, it affects libido, vasomotor symptoms, that's hot flashes, mood, well-being, bone structure, and muscle mass. I think women deserve to have adequate testosterone. This was what one of my women patients had done. Her testosterone was 10. Remember, optimal is around 50. Her physician wrote testosterone WNL, that means within normal limits, which it was. It was within normal limits. And it was also done as a female child. And the reason is that women don't have as much testosterone as men, and so frequently they're put on this female child panel instead of looking at as a female, an adult female, and what the optimum ranges are. This woman was 1/5 where she should be. This talks about estrogen. We're back to estrogen for a second. What this says is that you can, if you restore a woman's estrogen to optimal levels, you can get rid of depression, if that's what it's related to. I want to tell you about the case of the crying cleaner. January 11th, 2012, about a year ago. This woman who is near and dear to my heart showed up, and she was crying and depressed. I said, and she told me she was on citalopram. I said, are you having any hot flashes or night sweats? Oh, yeah, those have started a while. And she said, what can I do? I thought, and this is not a woman with gold-plated insurance. I mean, cost is a factor. So who am I going to send her to? Am I going to send her to somebody that's going to have to wait for 3 months to see her and write a bunch of high-priced labs and some medication she can't afford? Or am I going to treat appropriately? I decided to treat appropriately. I gave her oral estrogen. That is human-type estrogen, estradiol, not horse pee. Prometrium, that is also a prescription. That is bioidentical progesterone. And continue the citalopram, and she was better in 4 days. That's the power of hormones. None of this waiting for a month or two to get your levels up. You know, you get the hormones right, they get better. Want to talk about testosterone. I love this subject. I don't like what it does in men when it drops. the decline, it's not as abrupt as menopause. Menopause, women know that something has changed. Men, they don't know something has changed. Between 40 to 70 years old, the average male loses 2 inches of height, 15% of bone density, and 10 to 20 pounds of muscle. And the reason for that is testosterone drops. And at 70 years of age, 15% are completely impotent. And that's not a Viagra deficiency. So I went to one of my primary medical journals. This was the Alpha Male issue. And I read this article called Estrogen Nation. And they took note that for the last 4 to 5 decades, the average guy's testosterone level has declined in this country. And they quoted actually the peer-reviewed literature that recent years have seen a substantial and as yet unrecognized age-independent population level. What does that mean? It means it doesn't matter how old you are as a guy. You could be 20 and your testosterone level could be dropping. I've got 20-year-old patients with low testosterone. So, what do the golden arches and weanling rats have to do with each other? Guys, you will never look at going through the golden arches again after you see what I'm about to present. This article was frequent inadequate supply of micronutrients in fast food induces oxidative stress and inflammation in testicular tissues of weanling rats. And what that means in plain English is fast food is bad for you. And the reason is it's calorie rich but nutrient depleted, low in zinc. And so you have to have zinc for your antioxidants to work. Fast food gives you a severe decrease in antioxidant vitamins and zinc, correlates with inflammation in the testicular tissue, and decreased testosterone levels. So, guys, the next time you are tempted to drive through the Golden Arches drive-through, I just kind of look down at your lap and, think about your friends down there and what you're about to do to them. And you can also tell your hubbies, for the women here, or boyfriends, that might not be too good for you. This actually shows, now this has nothing to do with McDonald's, this is just aging. This is the normal decline of testosterone in guys' brains. It goes down. This is the decline in estradiol, not much. So if you're a guy and you're aging, your testosterone is going to go down in your body and your brain. Why is that important? Well, if you're a guy and you're living by yourself, the lower your testosterone, the worse you're going to do cognitively. The higher the testosterone, the better cognitive performance, even in the oldest age category. Men with the lowest quintile of testosterone, this is the bottom 20% of the class, did worse than men with the highest. The highest bioavailable testosterone was more significant than total testosterone intelligence level, mood, smoking, and booze in terms of cognition. High testosterone is a good thing. That was cognition. This is mood. If you had low testosterone, you had a 4-fold increased risk of depression. And if you weren't depressed at the time the study was done, there was a significantly decreased time to diagnosis. The depression was inversely related to the total testosterone with a statistical significance of less than 280. I saw a guy today with a level of 202. And it's not just cognition and mood. It's, are you going to survive? So for guys over 40 that said, we have got really great health, we feel really good on a survey, when their labs were done, their testosterone, their estradiol, and so forth had no decrease compared to their peers. This is testosterone versus heart disease. Men with coronary artery disease have significantly lower levels of androgens, that's testosterone, than controls. Here is another study. There is early evidence that physiological testosterone replacement, that means replacing to optimal levels, not to bodybuilder, hunkazoid type levels, is extremely safe and may reduce cardiovascular mortality. So let's take testosterone plus DHEA and thyroid. Case report. This was my patient before he got on treatment. We got him on a dairy-free diet, vitamin D3, Armour thyroid, testosterone, multivitamin, zinc, DHEA, and coenzyme Q10. This is what he looked like 15 months later. His labs were normal here, but they weren't optimal. Testosterone is really good for guys' brains. Here's one study that says testosterone could have protective effects on brain function. Testosterone levels are lower in Alzheimer's cases compared to controls. That means the lower your testosterone, the higher the risk for Alzheimer's. Not good. Positive associations have been found between testosterone and global cognition, memory, executive function, and spatial performance. Guys, we really need testosterone. Now, how many have heard that testosterone will raise a guy's risk of prostate cancer? Okay, one brave person up here in the front is holding. If you haven't heard it, then you either haven't been plugged in or you're talking to really bright people who know the difference. So, this is actually the facts. Prostate cancer was found about twice as much in the lowest 30%, the lowest tertile of testosterone, compared to the highest. So what does that mean, casino ASTAR-wise? It means if you're in the bottom third of the class in terms of testosterone, your risk of getting prostate cancer is double what it would be if your level was optimal. That's not very good. There are several papers showing a relationship between low testosterone and prostate cancer. Specifically, low testosterone has been associated with high-grade tumors, advanced stage of presentation, and worse prognosis. Ladies, you better go home, and if your husband or boyfriend doesn't know what his testosterone level is, you better find out. Pretty important. Benefits and minimal risk of testosterone. Here are the risks of low testosterone. You're not going to live as long, you're going to die of a heart attack, be obese, have poor muscle, limits on your mobility, your bones will get holes in them. And we're talking about guys here too. Frailty, cognitive impairment, depression, and higher risk for sleep apnea syndrome. Those are the risks of low testosterone. Here are the risks of treatment. None. When you look at the literature, none. Conclusions. Men with sexual dysfunction, visceral obesity, that means fat in the gut, and metabolic diseases should be screened for testosterone deficiency and treated. Young men with testosterone deficiency should also be treated. This is a case of the mismanaged executive, a 42-year-old male, frankly ADHD CEO. His background was in psychology. He presented for evaluation extremely stressed. He said, "I am so tired, I feel like I'm dying. I'm depressed." Now, this guy had a background in psychology. He should have known what depression was. He said, "I'm depressed." Actually, he wasn't. When I did his labs, he had low testosterone despite multiple pumps from a low-potency, FDA-approved, big pharma transdermal testosterone gel, which was being managed by his endocrinologist, and his level was low. He also had low thyroid, low DHEA. I gave him testosterone. He was so low and he needed help so fast, excuse me, I just started with 60 milligrams twice weekly, the intramuscular injection, gave him DHEA, Armour thyroid. He had a total resolution of his symptoms in 3 to 4 weeks. Didn't touch him with an antidepressant. Let's talk about obesity. It's a growing problem. How do you lose it? I used to tell my patients the story of the Doc Cady candy bar a day weight loss program. If you just starve yourself, you'll reduce your metabolism. That's not good. So you need to have a balance between lowering your consumption and burning 250 calories. That'd be like some time on the treadmill. So this is no candy bar, 250 calories, and a half to 3/4 hour on the treadmill. Net, 500 calories per day, you're going to lose a pound a week. Great idea. Doesn't work. And the reason is, as this book, Why We Get Fat, noted, it's the carbs that do it. And the carbs spike our insulin, and insulin makes us fat. The commonsensical thing, eat fewer carbs and sugar. Less of the white stuff. White bread, white flour, white milk. Glycemic index is a measure of how fast what you eat will spike your blood sugar. I see some friends in here that I've been after on this. The higher the number, the greater the blood sugar response. This is an example of a low glycemic index, and this is a high glycemic index. This is like jelly beans or jelly bellies. High glycemic index. This is one of the reasons that we're fat. This is the old FDA food pyramid, rest in peace, 2005. The basis of it was eat lots of grains. The notion was it's the fats that'll kill you, grains are healthy. That was the exact wrong thing to do. Let me walk you through your day. Here's how it goes. You start with what you think is a healthy breakfast, whole wheat toast, OJ, and coffee. You might as well pray, God, please make me fat. It spikes your blood sugar up and your insulin goes up. Insulin will begin dropping your blood sugar. Now follow this carefully. You got to get this first one, then it's downhill from there. So your blood sugar is coming down, 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 down. Now this is where you started. But insulin is still up here. What's that going to do? It's going to keep driving your blood sugar into your cells. Down, 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 down. Now you're going to get really hungry. So now you're going to get your morning snack, rice cakes and coffee. By the way, rice cakes is as high glycemic as jelly beans. Might as well eat jelly beans instead of your rice cakes. So that's going to spike your blood sugar. Your insulin comes back up. You're going to drop in another couple of hours. Now you're going to have your high glycemic lunch. Maybe a Big Mac, fries, and shake. Then you're going to spike your blood sugar again, spike the insulin. Insulin goes up, sugar goes down. Now you're craving a snack in the middle of the afternoon, so you have that ice cream, Cokes, chips. Then you do the same thing at dinner, and maybe if you eat a high-carb snack at bedtime, you'll wake up in the middle of the night hungry. Some of my patients do. Problem is, when you're up here with high insulin, you are in fat city. That's where you pack on the weight. If you want to get out of fat city, you eat low glycemic food. Then you don't spike your blood sugar, and then your insulin doesn't go up. Goodbye fat city, and you lose weight. The higher your insulin, it's like you're putting a force field over your fat cells, which keeps your body from burning fat. So I suggest you not do that. Here are the horrifying facts about the foods that you eat. If you set a glycemic index for glucose at 100, table sugar is 65, tofutti is 115, French bread, look at this, French bread, rice, and a baked potato are higher than table sugar. Ladies and gentlemen, you would be better off eating table sugar out of the bowl on your kitchen table, gram for gram, than eating this stuff in terms of what it does to your blood sugar. And then, check this out, this is rice cakes and jelly beans, 77 and 80. That's higher than the table sugar. Cheerios, just about as bad, breakfast of champions. Now, spaghetti, everybody thinks that spaghetti will make you fat. No, it's excessive consumption. White spaghetti, 41, look at this. Protein-enriched spaghetti, 27. That's actually low glycemic. That's good for you. Just got to monitor your consumption. This is what low glycemic looks like. Yes, you can find low glycemic in Evansville, Indiana. This was at a common chain restaurant here. This is what low glycemic will do. This is about 30 pounds off of one of my favorite Colts fans. Done very easily. So, what are you supposed to do with all this information that I just gave you? And I like this copier guy, the dude with the bow tie. His punchline is, it's really not that complicated. So what I have told you, it's really not that complicated. This is where these are the problems, and this is what you do. So you have stress, job life stress. There are things you can do. This is the psychological. Meditation, spiritual practice, Tai Chi, Qigong, make needed life changes. I've had some people divorce. I've had other people get marital counseling. Abnormal hormones. The behavior or status, you don't know what they are, or they're presumptively low. So what you do, you get your levels, saliva or blood, and you can check neurotransmitters. And then here are all the interventions that we talked about. Thyroid, DHEA. We can optimize and support cortisol. We can use hormones. Growth hormone I don't typically use, but it's a innocent bystander as it goes up with some of the other things. We can use amino acid precursor loading for neurotransmitters, not necessarily Prozac, Paxil, Zoloft, Vibrid. We can use prescriptive agents, antidepressants, and neurostimulants. My colleague, Dr. Gabhart, and I have some lectures coming up. We're going to keep talking about this stuff here. I close with this provocative question. How obvious does it have to be? You don't have to be a doctor to figure out this dude probably has a problem. He fell on that concrete drill and ran it through his eye. So this was an actual X-ray in the radiology department. That's obvious. Hopefully I've made it obvious for you tonight. So I suggest we start checking those levels. I love what Thomas Huxley said. Sit down before fact as a little child. Be prepared to give up every preconceived notion. Follow humbly wherever nature leads, or you shall learn nothing. So I hope that tonight you have sat down before truth as a child. You have taken up some of this information, and you will use it for your betterment and hopefully a long, successful, happy, and peak performance kind of life. Thank you very much. I'll be happy to answer a few questions, and then we should all get home so I won't keep you up past your bedtime. Any questions? Yes, ma'am.
How early, I mean, at what age can women's testosterone start to decrease to a point to where we've got some of the issues that you discussed?
20s.
Really? Okay.
Yes.
Okay.
I've seen it. A quick story. There was a young lady that was at Synergenics. She was actually on the staff. And at Synergenics Medical Institute, all the staff get an age management workup. And actually there was another, she told me about this, but there was another woman patient. I'll take that back. There was a woman patient there who came to be evaluated. She was found to have low testosterone level. She was started on testosterone, and she was in Vegas for a while. And so on the day that she left, she called her Synergenics physician and said, "How fast does this stuff work?" And he said, "Why?" She said, "Because I'm sitting in the airport undressing men with my eyes." That, it worked that fast within a couple of days. I mean, I'm not suggesting that you, as Jimmy Carter would say, lust in your heart. But the notion was that it improved her libido that quickly. Other questions? That it? All right. Thanks for coming. Good night.